Welcome to the Age-Friendly Health Systems virtual reality case. This case is an exercise funded by the NSU South Florida Geriatric Workforce Enhancement Program to educate non-geriatricians in the care of the elderly. The goal is to address four important elements of care critical to the elderly, referred to here as the four M's. They are mobility, mentation, medications, and what matters most. You are about to embark on a self-guided healthcare journey of an elderly woman named Millie. The scenario will take place at various stages of her journey, which we hope will illustrate the 4M framework for you. You will view each stage, answer some questions, and be directed to the next stage. Feel free to move through the stages at your own pace. Ready to start? Go ahead and click Stage 1 Load button and begin. Millie is an 87-year-old female with a history of hypertension, diabetes mellitus, diabetic peripheral neuropathy, urinary incontinence, chronic kidney disease, osteoarthritis, and macular degeneration. She has fallen while going to the bathroom at night. She was able to press her emergency alert button. The paramedics found her in a darkened hallway where she was noted to be tremulous, diaphoretic, and having a blood glucose level of 55 milligrams per deciliter. Her blood pressure was noted to be 135/80. She is now in the emergency room, and a right-sided intertrochanteric fracture has been diagnosed. Regarding her medication history, Millie was placed on sulfamethoxazole trimethoprim for a urinary tract infection a week ago. She is also on lisinopril, 10 milligrams daily, amlodipine, 5 milligrams daily, glyburide, 10 milligrams daily, gabapentin, 300 milligrams 3 times daily, acetaminophen, 500 milligrams twice daily, and oxybutynin extended release, 5 milligrams daily. Millie was living independently at home and was widowed 7 years ago. She has been able to perform all of the basic activities of daily living, including dressing, toileting, transferring, feeding herself, and ambulating with the help of a cane. Her daughter would come by in the morning prior to work to make sure that her mother took all of her medications and had had breakfast. She would also buy Millie her groceries every week, since Millie was unable to drive due to her macular degeneration. Millie's daughter would come at night to help bathe her mother a few times a week. Grab bars were installed in the shower, and a shower chair was placed. CAM, or confusional assessment method, is a diagnostic algorithm that assesses delirium. It is mandatory to have the first two features of the CAM algorithm. Number one is the change in behavior and a fluctuating nature to behavior. Number two is evidence of inattention and distractibility. Two more features are disorganized thinking, characterized as illogical and unclear ideas. And the final feature is an alteration in consciousness that may have a wide presentation, such as hyperactive behavior with extreme agitation or withdrawal and a stuporous state. It is mandatory to have the first two features of the CAM assessment plus either feature 3 or 4. With Millie's assessment of delirium, her change in behavior was sudden, and she is displaying inattention when we try to ask her questions. The first two mandatory features are met. In addition, Millie is easily distractible and has disorganized thinking. It appears that she is withdrawn and lethargic, not her usual state as noted by her daughter. Therefore, Millie has all 4 features of the confusion assessment method algorithm. Surgery is on the second hospital day, and a bipolar hip prosthesis is implanted. On postoperative day 2, Millie has had little urinary output, and her bladder is noted to be palpable. A bladder scan demonstrates a post-void residual of 600 milliliters, confirming urinary retention. An indwelling Foley catheter is placed, and Millie's internist prescribes a morphine pump to control her pain and temazepam to help with sleep. Millie's daughter is upset, reporting to the nurses that her mother appears confused and disoriented. Millie appears to be sleeping excessively. Millie's internist evaluates her and discontinues her PCA pump and sleeping medication. 6 to 8 hours later, Millie appears less sedated, but still has waxing and waning cognition. Millie cannot fully bear weight on the right side and has weakened proximal muscles. Her nutritional intake has been limited. Due to continued confusion, physical therapy has been unable to complete an initial evaluation or follow-up. Millie demonstrates inability to bear weight on the right lower extremity, and therapists have been attempting active assistive activities at the bedside. Otherwise, Millie has essentially been bedbound with very little time spent out of bed. On day 4, Millie is found to have a stage 2 sacral pressure sore. The next day, Millie and her daughter meet with the discharge planner. Millie's daughter would like to consider an assisted living facility after Millie completes rehabilitation in the skilled nursing facility. The patient disagrees with placement in the ALF. Advanced directives have never been discussed with Millie, and she is full code status. However, Millie stated in prior outpatient visits that should she be impaired and unable to make decisions, she would allow her daughter to help as her healthcare proxy. Advanced directives or advanced care planning is best discussed when there are no healthcare emergencies. However, many times discussions need to be in the hospital during an acute illness. Full cardiopulmonary resuscitation performed on a patient with advanced age and comorbidities is often inaccessible and comes with consequences. Cardiopulmonary resuscitation involves compressing the ribs 1.5 to 2 inches deep and may result in rib fractures and possible pneumothorax, which may necessitate a chest tube. Millie's daughter acts as her healthcare surrogate and opts to keep Millie at full code status, wanting everything possible to be done. Millie is admitted for rehabilitation to a skilled nursing facility for 3 weeks. She's now able to walk using a wheeled walker and transfer to an assisted living facility. She is able to dress and toilet herself, but needs supervision with showering. Millie fell at night on her way to the bathroom. Falls can be a marker for poor health and declining function. Advanced age, medications, cognitive impairment, and sensory deficits all contribute to increased risk for falls. Some fall risks can be lessened by removing throw rugs and electrical cords, clearing away obstacles along the path from bed to bathroom, providing adequate lighting, repairing irregular floor surfaces, and keeping pets from underfoot. Sensory deficits such as poor eyesight and hearing should also be addressed. Tug, or timed up and go, is a test of functional mobility and balance. It is also a useful tool in assessing fall risk. The patient is asked to arise from a sitting position with his or her arms in their lap, walk 10 meters, turn, and return and sit. 10 seconds or less is considered good. 13 seconds or longer is predictive of fall risk. This exercise has demonstrated the importance of aligning care goals with an older adult's care needs, goals, and preferences. 4 domains were explored, the 4 M's. Mobility, in this example, the loss thereof, with resultant loss of independence and well-being. Mentation, delirium, and its impact on recovery is central to the theme of today's exercise. Medication, a powerful healthcare tool, but with attendant risks such as hypoglycemia. And finally, what matters most. We recognize the importance of the right of our elderly patient to decide for herself what is important to her in her care and her desired goals. We hope you will reflect on this scenario as you begin to care for your own patients.